Hello, everyone. Hi, my name is Alex, and we are the Pitt CMU team, and we're excited to show our product today, AIquitas. AIquitas was built around one simple ethos. Every patient deserves a clinical trial. What was our research and ideation process? We started off by asking ourselves 4 key questions. 1, what is the greatest racial or social economic inequity that we can address? 2, what is the economic impact if we fix this disparity? 3, is there high quality data that makes any solution we have generalizable and actually work in the real world? And 4, is there a unique opportunity for AI to play in addressing this inequity? From here, we narrowed that down on the problem of lack of diversity in clinical trials, specifically using breast cancer as a pilot case. Less than 10% of the population in clinical trials of the last 25 years were people of color. Less than 20% of FDA-approved drugs have clinical trial data regarding treatment benefits or side effects for Black patients. That results in over a 38% increase in breast cancer mortality among Black women from 2000 to 2010 when compared to white women. And if the gap had been closed, we could have saved $1.2 trillion in costs from 2003 to 2006.
This is what a modern clinical trial looks like today, with study participants having little influence and ability to interact within the system. These findings painted a grim picture. To dive deeper into the causes of this problem, we interviewed patients, physicians, FDA scientists, as well as pharmaceutical research directors. And 2 key themes were repeated throughout the interviews and subsequent research. 1, trials are designed with a trial-centered perspective. And 2, many patients, especially vulnerable and underrepresented populations such as women, Hispanics, African Americans, and Asians are often not asked to participate in a clinical trial because there's this overbearing assumption that they will not. We needed to transform our thinking to a patient-centered perspective. But one massive barrier exists within patient enrollment: complexity. There is nothing stopping any one of us today from going to sign up for a clinical trial, but a doctor's referral is not a prerequisite. However, that would require you to have the ability to navigate all of these stakeholders, find all the relevant clinical trials near you, and then go by your own personal assessment to determine if you meet all of the clinical trials inclusion and exclusion criteria. And unfortunately, overcoming this barrier is not feasible nor possible for many Americans. Therefore, there are several contributing factors to this barrier, and 3 major pain points exist on both sides of the equation. For patients, there is a lack of trust towards the institution, low health literacy, and a lack of decision-making support. For physicians, there is perception bias, time constraints and work overload, and a lack of awareness for potential participants of clinical trials. So what is our approach to breaking down this barrier and solving this problem? Our solution is AIquitas, which using machine learning algorithms that intelligently compares patient records with clinical trial language and evaluates compatibility scores.
So AIquitas uses real-time data from clinicaltrials.gov API to find relevant trials. It simultaneously pulls patient EHR data from sources like the All of Us Research Hub. Our experiments were focused on breast cancer records, consisting of about 8,000 patient records and 6,000 trials. However, from the ground up, we've designed our system to be seamlessly scalable to other disease types. Our entire pipeline can be summarized in the following diagram. We first mine and parse the trial data to extract the inclusion and exclusion criteria. For the patient data, we aggregated over the patient ID to obtain EHR codes and the corresponding text. We then encode these text strings using clinical BioBERT, which is the unsupervised language model trained on biomedical datasets. As many of you may know, BERT is a transformer model commonly used for language processing tasks like entity recognition. It consists of the encoder part of the transformer architecture and is capable of representing contextual meaning of a sentence in the form of a vector. For our domain, we chose BioBERT, which adds the PubMed and the PMC datasets to the original corpora of BERT used by Google. Furthermore, to adapt our system to the challenging task of tokenizing and better representing free clinical text, the model that we used was fine-tuned on the MIMIC3 and the MedNLI datasets. Now, once we have these embeddings, we can use them to calculate the affinity of a trial with a patient. Our matching algorithm uses cosine similarity metrics to compare each patient code to each of the inclusion and exclusion criteria. By holding the patient record constant and switching out the clinical trial material, we're able to make insights into compatibility, such as the primary neoplasm of the breast, but also other multifactorial criteria, such as the ECOG status or correlations between diabetes and hypertension. By focusing on clinical compatibility and still considering other factors like location and the patient preferences, AIquitas outperforms its competitors.
So you might be asking yourself, how do we know that this is real? How do you know it's not just completely random? We created 3 tiers of tests to assess the system. First, we wanted it to compare breast cancer trials versus diabetes trials for patients. Is it able to accurately give that for breast cancer patients? It came out with a 95% accuracy. We then made it harder. We made breast cancer versus lung cancer, and this gets a little more difficult, so we get 83% accuracy. We then had our hardest test, where we took a patient and took their top 10 trials based off of the system, randomly mixed them up and gave them to domain experts to rank on their own, and then compare the 2 rankings using a discounted cumulative gain, and came out with a normalized value of 0.84 with a maximum score of 1.
Now we proudly present to you the prototype of our solution. First, I'd like you to meet Deborah. Deborah is the patient with triple-negative breast cancer. She is overwhelmed by her breast cancer diagnosis and struggles to understand her treatment option. Her goal is to find a treatment plan, including clinical trials, to work best for her and make informed decisions that helps her to feel safe and reassured. At the same time, Dr. Evans feels for her and want to help her. However, she might challenged by having clinical workload and unable to give each patient enough time. The goal is to improve the efficiency and effectiveness of the clinical trial screening process to ensure each patient have the access to the latest treatment. So let's take a look at how AIquitas can help both of them in the process.
We start out with an interface that seamlessly builds on top of most patient portals that already exist today, such as My UPMC at Pitt. This allows patients to, 1, express their preferences when it comes to clinical trials, 2, get more information, 3, find communities such as other people who are currently in clinical trials or who want to discuss their experience, but most critically, allow them to express their preferences about distance and how far they'd like to travel, what phase trial they're interested in, before accessing the AIquitas interface that automatically calculates the best trials for them. This means that they can not only get more decision support, but they can also filter it and be able to have better explained results and work with their physician. Even if their physician doesn't want to work with them, they can, and they can do it themselves. But the shining part of AIquitas comes from collaboration. By collaborating with their physician, AIquitas also gives you explainable results. If you pull up any individual trial, it will tell you which criteria are already compatible because those were able to be checked from the patient record. If it's not highlighted, that means the physician has to check. But our goal here isn't to do the job of physician, it's to reduce the number of patient hours and physician hours by over 90%, so that every minute spent with the patient can be used for the more valuable portion of building a trusting relationship. You can then save trials, you can then compare them side by side. And in this way, we're enabling oncologists to have better opportunities to bring patients to clinical trials that are better fitted for them.
With AIquitas, the patients benefit from personalized recommendations based on their personal medical records, and therefore improved health outcomes due to improved trial quality, and most importantly, increased patient autonomy and empowerment. At the same time, the doctors benefit from streamlined experience in the trial selection for patients. The assisted decision-making process helps them reduce the cognitive demand from their clinical load. And this would motivate the physicians to be more proactively using AIquitas in their clinical trial process and therefore improve trial diversity.
So what does this look like in the end game? Every patient now gets a clinical trial, regardless of their socioeconomic status and race. We get increased transparency on participation from a patient-centered perspective. Because right now, if you go to UPMC and you have a medical oncologist, he probably could refer you to the clinical trials currently happening there. But he doesn't know the ones happening at Allegheny Health Network 3 blocks down the street, nor does he know the ones at Ohio Valley State or even here in Northwestern. AIquitas cuts that apart. AIquitas does a regional or even national level search so that you know the best trials in your area, even if it's not directly at your current hospital. And now physicians can communicate and combine trial pools to give patients better outcomes. So what's next for us? We're looking forward to pushing this to a publication. We're scheduled to give a talk at the AMIA Clinical Informatics Conference here in Chicago later this month. We are currently engaged in clinical partnerships, working with clinicians to adjust their criteria, as well as to see how this affects their relationship, as well as commercial partnerships in implementing this at UPMC through an IRB and our R3 Institute. We're also looking to validate other functions using AIquitas data model, such as a trial fixer that will assess clinical trial language and see which ones contribute most to a reduced diverse patient pool. With that, I'd like to thank all the people who have brought us here today. Dr. Rema Padman, our mentor, could not have done this without her. Alexandra Lutz from CMU is the administrative assistant who brought us all together, as well as all of the people who are willing to be interviewed by us, to contribute their valuable feedback to these ideas, and to really help us bring together, as well as our hosts at Northwestern, who actually got us into a meeting with the Digital Medicine Society, and from there a path to the FDA. So thank you. From there, any questions?
About 9 minutes for questions.
So how do you take this to market? Where does it get integrated? Does it,
You click on value flow.
and is it at the, okay.
So our plan is for clinical trial sponsors to pay partially the hospital to allow us to build it on top of like the My UPMC portal, as well as to pay us for our work. This means that the hospital can now provide better treatment options, plus they get money, and we are able to then give better treatment guidance to patients. The value to a clinical trial sponsor is that it costs a lot to start a trial at Cleveland Clinic, UPMC, Northwestern. But if you're able to just have one starting point at Cleveland Clinic, but also now have referrals from a 300-mile radius, you're going to save a lot more by paying us a subscription fee.
But then the flip side of that is now you're competing against clinical trials where I can keep that patient within our institution.
Mhm.
Not saying that's the right thing to do,
Mhm.
but unfortunately, that's the business of medicine.
Mhm.
And so organizations want to keep those patients within their four walls so that they're enrolling for their clinical trials,
Mhm.
because that's where the downstream revenue comes from. And so I'll take the Pittsburgh market, Allegheny Health Network and UPMC are doing this
Yeah.
all day.
Yeah.
So how do you actually get them both to actually cross-refer to make it as equitable as possible?
There was some concern about that for sure, but what we noticed when we talked to both clinical trial investigators and pharmaceutical reps is oftentimes there are these kingpin institutions in the region, such as UPMC, Northwestern, University of Chicago might be a little more of a duality, but what's happening a lot of the times is that the patients who are most vulnerable aren't going to these big academic centers. They live 70 miles outside of town, so they're oncologists. There's a private clinic, a community oncologist, and they're the ones who are most likely to be seeing those diverse patients who need it the most. So what we think is going to happen is more of a centralization effect, which is if you are like from Fox Chapel and you don't come into UPMC at all, you go to Allegheny Health Network, they don't run clinical trials. They're pretty much about healthcare provision. We can now bring them over to UPMC and give them those opportunities. And hopefully Cleveland Clinic and UPMC can work together, and there's some negotiation there, but I think there's a big enough pool for everyone to play together in that.
Shalina has a question. Go ahead, Shalina.
Yeah, I spent a lot of time thinking about diversity in clinical trials a couple years ago. If I remember the literature correctly, your premise of this idea is focused on the fact that people don't join clinical trials because they don't know about it. However, even if you give them information, my understanding is most of the times they don't join clinical trials for a variety of other reasons. One of which you just talked about is that a lot of times patients don't trust big academic institutions. So what I have heard is people in the community, even if you refer them to the academic institution, because they don't have the trust, they don't go. So this won't necessarily solve that problem of them going to the institution, right? Because of the lack of trust. And then also, are you providing information about clinical trials, the utility of clinical trials, because people still think, I don't want to be a guinea pig. So I like your idea of making the information more accessible to everyone, but I'm just not sure if this is like the most significant barrier. Like if I think of a pie of what are the reasons why people of color aren't enrolling in clinical trials. From what I've read, and I forgot the name of the consortia that did like an in-depth study related to it. Part of it, I know people have focused on like providing transportation for clinical trials, providing more information related to like reimbursement for care, etc. But I would just say double click to make sure that access to information, which is what your solution is focused on, is a full barrier. Because I think trust in academic institutions. Also, I've heard doctors don't like to enroll patients of color in their trial because they think they'll be lost to follow-up, which won't look good on the pharma side. So I would just say, make sure you're considering all of the other factors that are barriers to clinical trials to ensure that your solution is truly solving like the greatest need within that. I'm not sure if the greatest need is lack of education around it. You know what I mean?
Yeah. Thank you for that question. And your point is is well taken. It's definitely a huge issue because there's so much history behind mistrust in institutions, especially for minorities. We're trying to address that from a two-pronged approach. First is that what we noticed when we were interviewing breast cancer patient advocates, for example, is that oftentimes they don't trust the institution, but their own oncologist, for example, that they do have an existing relationship with, they do trust or are willing to communicate with. The problem then is that if the oncologist is seeing 20, 30 patients a day, they don't have time to review 11, 20 something trials at 30 minutes a piece when they only get 15 minutes with each patient. So that's why our focus was on reducing physician time. The second prong was communication. We noticed that a lot of that really good work comes from community outreach, reaching community leaders, which is why we integrated it to a patient portal level where people who are in this system or people who want to be part of the system can communicate about their past experiences on the forum and connect with other like-minded individuals to start rebuild that sense of community and trust in the institution, although that will take time due to just the historic bad things that American healthcare has done in racial minorities.
Mine's a little bit more, it continues on the same theme, because from the pharma side, there are so many providers that just support a clinical trial. There are so many. So if you're just talking to the pharma person, they outsource those activities to other people to get the recruitment done. Have you talked to those people who are on the ground doing the recruiting for the actual clinical trials? Because the surgeons and the doctors are part of it, the patients are part of it, but who's actually doing the heavy lifting and actually gets paid to recruit them? So you kind of want to have all of this mapped out, and I think it goes to the other judge's comment, like what are all the pain points in all of those different verticals, because there's a lot of players here that you got to kind of understand how it goes from the pharma who actually funds this whole thing. It's not cheap to making sure you're getting the value. Where are you going to solve that? Because it is, the pharma company wants this, right? There's a lot of attention to this, but there's so many players involved in this whole thing that it's not just the docs and the patients.
Sorry, this idea was actually inspired from some of the work that we kind of do. Actually, I actually work for a hospital back in Cleveland, University Hospital, where I work to find patients that are eligible for clinical trials. But what I have to do is do it manually through coding in Python and pulling data from our enterprise data warehouse, right? Where I have to manually go read the clinical trials protocol and try to match it to map some of like the ICD standing diagnosis, CPT, but usually most of the time, there's not a specific code that the code might not be available in the patient's record due to missing data, or there's not a code that specifically kind of identifies the condition that they're trying to state, or it's available in a doctor's note message, right? So I think the purpose of AIquitas was try to, like he said, alleviate that patient time to try to just find inclusion criteria that is easily searchable within the enterprise data warehouse that we're able to pull. And then the extra time that a physician has, they can use that to go through a manual chart review and find that inclusion criteria that they're looking for. But like you said, like there's a lot of work that goes just to start at a clinical trial. And the first one is finding patient, like making sure the clinical trial is even feasible. Like within our hospital, we have to make sure that a clinical trial is there's 5 times the number of patients that they want for enrollment. So if they want 300 patients, we want to make sure there's 1,500 patients available. So there's a lot of like disconnect between, although there are 1,500 patients available, the physician then has to go through all of it and review, and maybe only 150 will be eligible for the clinical trial.
So my tip would be your story and your pitch should talk about what you're dealing with right then and there. Because now you're the actual person who you're trying to solve the problem for, not the patient, not the doc. It's people like you that are doing this job. And that piece, if you include that in your story, it helps create the connection to why this is important, how it saves you money, you time, which ultimately saves money, time in hospital, et cetera, et cetera. And then there's other issues too.
Thank you. Thank you.
Thank you.